All right, so we stopped at the signs and symptoms. Let's go now to management. So the ECG again, 12-lead ECG is essential to make a diagnosis. We need it right away in order to determine the next step. So we confirm an MI based on your ECG, and then that will be supported by your cardiac enzymes. First is pain. Morphine is used for pain. The patient may have received morphine also in the ambulance if that's how they came in, as well as aspirin and even nitroglycerin. So the patient, the acronym is MONA, but that's not in that order. Okay, doesn't mean morphine is necessarily the first one given, followed by oxygen and nitro and aspirin. So in actual practice, it's more like ONAM because you get oxygen first, and then they'll give you a spray of nitro or a nitro sublingual, and then they'll give you the aspirin, whichever comes first, and the of course morphine. Okay, it's not like days come between each one. Okay, this is a matter of a few seconds. So within the first minute, you may receive all four. So this is our best practice. So let's say the chest pain occurred in the hospital. So this is our order: airway, breathing, circulation. Put the patient on an ECG right away. Assess the pain. A pain here assessment must be complete. Should be PQRST complete, not just how bad is it. So location, intensity, what started it on, what started it, what makes it worse, what makes it better, etc. And any accompanying symptoms. It's crucial that you ask about the associated symptoms, not just the pain, because that will help you distinguish whether this is angina versus an MI. Vital signs, if they don't have access yet, establish a vascular access. And of course, you would have yelled out to someone already to call rapid response. By the time rapid response comes, your ECG should be done already. And then the patient will be hooked up to a continuous cardiac monitor afterwards. And we continue pain relief with nitro and or morphine, and then maintain an oxygen saturation of 90 or better. As far as nitro, let me go back here because I want to get the nitro out of the way first, because there's a difference here if, let's say, the patient didn't have the chest pain in the hospital. So let's say they had it at home. So we'll leave chart 38.3 for a minute. Let's go to if the chest pain occurs at home.
Professor.
Yeah.
Hello.
I
have a question. Would you give the patient aspirin before you give nitro for chest pain, or does it matter?
Yes. The patient will receive aspirin.
Okay.
Okay, so here is your teaching for nitro. So patients with known chronic stable angina or any other anginal episodes, the patient will be prescribed nitroglycerin, or after an MI. So a patient that suffers an MI, they will be sent home with a prescription for nitroglycerin. So this is your teaching for how to use it. Teach them to bring the whole bottle. The bottle is so small anyway. It's not like it's going to fill up your purse. So bring the bottle in its original container. Do not transfer it to a pill organizer or a Ziploc bag. Keep it in its original container. Again, the container is a small, tiny brown bottle. It's brown because you can't expose it to light. At the first sign of chest pain or discomfort, take it under your tongue, or if you have the spray instead, take one spray under your tongue. Now, if the mouth is dry, which is usually what happens, because again, the chest pain means there's ischemia. That means your blood pressure starts to drop the moment that starts. So therefore, once the catecholamines are released, that will cause vasoconstriction. So your mouth is dry. Now, in that instance, you may where's the 5 ml of water? Anyway, I'll show you the once I find it. So there's a it's acceptable to give the patient 5 ml of water, but that's not used to swallow the tablet. That's used to moisten the mouth, because if you put it in a dry tongue, 5 minutes later, you'll find the same tablet under the tongue. It will not dissolve unless there is moisture. So if the mouth obviously is dry, give them 5 ml of water to moisten the mouth. That way your tablet dissolves. Unless, of course, you're using a spray. So wait 5 minutes. 5 minutes later, no results, call 911. Again, this is the home, okay? This is at home. In the hospital, of course, you're already in the hospital. So instead of calling 911, you will activate rapid response. Is that clear? Now, why do we call 911 or activate rapid response after one tablet with no relief?
We need to know, because we said earlier that chronic stable angina is the one responding to nitro, and then if that pain didn't respond to, it's most likely to be myocardial infarction.
Very good. That's the answer. So obviously one tablet did not work. Is it angina?
No, nope, not chronic stable.
Right, so therefore it didn't respond to nitro. It's not likely to be angina. So even if you're wrong, no, you just say my bad, but I'm following protocol. There was no relief, so I called you guys. While waiting for EMS or RRT, you continue the protocol. So 5 minutes later, you give another nitro, and then another 5 after that. There should be another, right here. So here it is. It's on the drug alert, right above 3811. So there should be a tingling sensation. That means the tablet is potent. It has not, it's not expired. It hasn't lost its potency. Same thing for the spray. Okay, there should be a tingling sensation or a burning sensation under the tongue. That's expected. And of course, if a patient complains of a headache, so yes, that's another thing, because this is a vasodilator, so it will increase blood flow to the brain, increase intracranial pressure, so there will be a headache. All right, so that's how you teach them about nitro. I'll come back to this later because I was just finishing up the nitro. Okay, let's go back to 774. All right, so we follow chest pain protocol to the letter. So ECG, oxygen, morphine, nitro, aspirin. So here we go, aspirin, nitro, follow protocol. Here is a few warnings. So if a patient has been taking phosphodiesterase inhibitors, like what are you on, Ramel? Are you on this or the Cialis one? What you on?
The Cialis.
Okay, good. All right. I'm only on Lipitor. And unfortunately, it doesn't have that added benefit. Oh, here's the 5 ml. Okay. Again, this is not to swallow the pill. All right. This is to allow the tablet to dissolve, because again, vasoconstriction causes the dry mouth. Watch your blood pressure. because that is a natural consequence of vasodilation. So this is the reason angina usually responds to nitro. So if there's no relief after one tablet, we're probably not dealing with angina. Okay, so once we complete the 3 nitros, no relief of chest pain, the patient continues to have chest pain, obviously it's an MI. So as the patient is being prepared for transport to the cath lab, because that's most likely what's going to happen, you will receive an order to start nitroglycerin drip. Okay, so obviously the short-acting 0.4 milligrams of nitro sublingual or the spray isn't working, so we'll give the patient a continuous infusion. I believe we have this on the test already. We discussed this, right? Like 5 micrograms per
No,
hour. We did, right?
no.
How come I feel like I've already done it?
No, with us.
This deja vu.
Can you please go through an example real quick?
Okay, so the standard order is nitro, and the doctor will say this is infusion, nitroglycerin infusion. Start it at 40 micrograms per minute, and then increase, because this will be titration, increase by 5 micrograms per minute every 3 to 5 minutes for chest pain. Meaning if the patient still has chest pain, you keep increasing it by 5 microgram increments. Okay, so you do that every 5 minutes. So therefore you ask the patient, 3 to 5 minutes later, after increasing the dose, say, how is your chest pain? Rate your chest pain. Is it still the same? And then based on that, if it's still present, if it decreases, you still continue anyway, because it's for chest pain control until the patient is pain free. Okay, so as long as there's chest pain, you keep increasing by 5 microgram increments. So your pharmacist will send you a bag, a 250 ml bag containing, let's say, nitroglycerin, 25 milligrams in 250 ml. So how do you solve this? So if it is your initial infusion, so that means 40 divided by 1,000, right? Whatever that thing comes out, and then you multiply that by 60 so that you will get milligrams per hour. So we converted micrograms to milligram and then multiply by 60 to get the hour. And then once you get this is pretty much your order, because here this is just micrograms per minute. So therefore you need your actual order, and then you can do D over H now. So whatever this is divided by 25 times 250. And that is your initial infusion. Now, as far as the micrograms per minute, 5 minutes later, you do the same thing. So convert this to milligram per hour. And again, divide this by that. Then once you get this, so let's say this comes out as 1.5 ml plus this one. So whatever, let's say this is D, okay? So whatever D is plus 1.5 ml per hour, that is your new rate 5 minutes later. And then so on. 5 minutes later again, there's still chest pain, but you already know the titration, so you just keep adding 1.5 ml to your rate every 5 minutes. So this is the same as, let's say you're dealing with a septic shock patient. You get your dopamine infusion. So the same thing. So all you need is your initial and your titration rates. And after that, you just keep going from there.
What you're saying is that you add the initial dosage, whatever that was, plus.
So this step here is your initial infusion, right? This is your 40 microgram per minute.
Yeah.
So you're trying to figure out what your initial infusion is. How many mLs per hour will you run this bag? So based on 40 micrograms per minute. So again, convert that to milligram per hour first right here. And then you can go D over H now. This divided by this times this equals your initial infusion, ml per hour. And then you also calculate this one in the same manner. And this one, let's say, comes out as 1.5. So therefore, you add it to your initial infusion rate. And this is now your titration 5 minutes later. Make sense?
Yeah.
Okay. And then every 5 minutes thereafter, patient continues to have chest pain. You keep doing the same. Until, of course, you're sending the patient off. Cath lab comes. They'll pick up your patient. So they'll take them with your nitroglycerin infusion. On top of this, the patient may also receive heparin to prevent new clots from forming. Therefore, you don't get another MI on another coronary artery. So besides your nitro, patient will also be receiving heparin, also in a continuous infusion. And what they'll do is just stop the heparin when they reach the cath lab, when it's time to make the incision in the radial artery or in the femoral to insert the catheter. Then they'll just stop the heparin infusion. Yes, Maria, you have a question?
What's the max dose of nitro that we can go max it up to? What?
The doctor will give you a order max, but typically it'll be a while before. At that point, the patient's already in the cath lab at that point. So we typically have never had to reach maximum.
Okay.
Okay. These are your drug charts. Testable part is, of course, the second column. So I can ask you about nitrates. We know this already, especially Ramel. Now, there are different forms of nitro. In the acute episode, of course, we're only using the pills, the sublingual pill, the spray, or the IV infusion. For long-term vasodilation, meaning this is now after the acute episode, then the patient may switch to a nitro patch or ointment because it's more long-lasting. Of course, this is an ointment that may make sure you remove the other ointment before you put on a new one. Another is if this is used long-term, meaning if the patient will be on the nitro ointment at home also, meaning for life they'll be wearing a nitro ointment. Now take note that it should be only on for 12 hours. Okay, there should be another 12 hours that the patient has a nitrate-free period, because you can easily develop tolerance to something you use constantly. All right, so in the hospital, you'll expect to see the day shift pretty much can't remember if it's night shift, but anyway, one shift puts it on, the other shift takes it off. Does that make sense? So on your MAR, when you open your MAR for nitro ointment, it'll be nitrobid ointment. So nitrobid will have an order to apply on a certain time, and then the next time, 12 hours later, will say remove. Does that make sense? That way you're reminded to take it off. Okay, so it will appear like that on your mark. Okay. Here's another warning about nitro when you're defibrillating patient. Because in in our hurrying, we tend to forget about the nitro because it is flammable. Okay? I mean, it's nitroglycerin. Beta blockers. This is used during the acute episode. If you notice, there is no calcium channel blockers used here during the acute episode. Again, this is only during the acute coronary syndrome episode. Okay, so we're only using nitrates, beta blockers, and antiplatelets. Calcium channel blockers will be used later after the acute episode has subsided. Okay, so what's the purpose of morphine? Why are we giving morphine? So this is the answer. You see it on the test question, even on the NCLEX, because I have had students say, yeah, they got the morphine question. So this is the rationale. It's not really, I mean, we give it for pain, but technically what it does, because the pain here, remember, is caused by ischemia. So the morphine here, unlike other pain, wherein you give pain, like you have back pain or some chronic pain, this one, the pain in an ACS is acute pain caused by ischemia. It's myocardial ischemia causing the pain. Morphine relaxes smooth muscle. And of course, it's a CNS depressant. So of course, it will also lower your respiratory rate, chillaxing the patient. So overall comfort is achieved. So plus it's a opioid, it's a pain medication. However, the pain here is really relieved not only by morphine, but also by your nitroglycerin. All right, so this is the answer. So morphine is going to decrease or reduce myocardial oxygen demand. So the heart rate here will drop as well, together with, again, you gave a beta blocker, so that will also help lower the heart rate. So once you lower the heart rate to 60 or less, then myocardial oxygen demand decreases, therefore it will increase oxygen flow to the myocardium. It's easy to OD on this thing because the patient will be complaining of chest pain, and then we tend to give it because it's given every 5 to 30 minutes. So that's a wide range. So you can give it every 5, every 10, depending on the pain level. So you could potentially, plus remember this, during this episode, the patient has decreased cardiac output, right? So there will be less perfusion to the kidneys as well. So kidney function there might be a little injury here to the kidney. Remember that will cause buildup of your opioid here. So watch also for signs of toxicity and of course overdose, okay? But you have Narcan available. And after you give Narcan, that means it will reverse all the pain, all the effects of morphine causing pain to come back. So you're gonna have to give morphine again. The vasopressor therapy and especially vasopressor, we will discuss later because this is really used for cardiogenic shock already to increase cardiac output, to increase blood pressure, which happens when the patient goes into cardiogenic shock, which is in chapter 37. So we'll discuss and test that one later for the final exam. Here are your drug therapy again. Aspirin. For this chapter, it's not really that hard, right? I mean, we have the American Heart Association telling us what to do. So there's really no gray area here. You know exactly what to give. So you give the MONA, again, not exactly in that order. And then you do the ECG, and then depending on your findings, you prepare the patient for cath lab. But on the way to the cath lab, we switch to nitroglycerin infusion. So all these you already expect. Okay, so these are the standard. Every MI patient receives the standard treatment until they get to the cath lab, and then same thing as with stroke. Okay, there's a set of interventions you implement. Okay, there's really no wiggle room for the nurse or the doctor. Okay, so we have a standard um, treatment for these. So I don't anticipate, and the grades for the third exam isn't low at all. Okay, because of this reason, it's all black and white. When we get to airway, oh, we already did airway management, so it's the same also. So you can see we had a set of interventions on how to verify tube placement, what your maintenance are, how to prevent pneumonia. You understand what I'm saying? It's standard routine interventions. You understand what I'm saying?
Yes.
Yeah.
Yeah.
So as long as you read the textbook, then I mean, what other questions, uh, could I possibly ask? I mean, they're all here. Okay. So this one obviously is already afterwards. The patient will be these are some of the medications the patient will be discharged on after an MI. So from now on, they'll be on aspirin and or Plavix. Or if the doctor doesn't like this, they'll be put on ticagrelor. This is Brilinta. It's still an antiplatelet or antithrombic drug. Or you can have this one, Agrestat. Just make sure you give Tylenol for this one, because the patient does get a splitting headache. Typically, we give the Tylenol 15 to 30 minutes before we give this thing, just to make your patient comfortable, because once the headache starts, then they'll get aggravated, and then the patient's unstable to begin with. So don't forget the Tylenol first. Here's a drug alert for those drugs. Platelets, nothing new to you. You gave this also to a stroke patient on discharge. As far as anticoagulation therapy, this is achieved again by the heparin. This is started before the patient gets to cath lab. Then we just stop it because it has a short half-life. So we stop it approximately an hour before. And then we resume it after the procedure. Beta blockers obviously is given to stop the effects of epinephrine, because you don't want this patient's heart rate to be above 60. So you want to keep it around 60 or even in the 50s would be great for an MI patient. Side effects from beta blocker therapy. There's a bit change here, although in chapter 35 for heart failure, because we gave beta blockers there too, it said there we wanted the heart rate between 55 and 60, right? But in the absence of an order, of course, we will default to 60 as our threshold. But most cardiologists have actually never met a cardiologist that will tell you to worry if the patient's heart rate is below 60. So between 55 and 60 is the ideal heart rate once the patient has a MI or has had a history of MI. Pretty much remember that MI killed parts of the heart. We don't want that heart beating too fast. So we want to keep it low, keep it between 55 and 60. Along with the um, aspirin, Plavix. The patient also, this is all in preparation for discharge, okay? So the acute episode is over. We've done the PCI already, so the patient will be started on these discharge medications. So we have ACE inhibitors is standard or ARBs, never both. And we can also have, wait a minute, they can be on both because of Entresto. Entresto is a combination drug. Um, and then of course for cholesterol, the patient will be on statin unless contraindicated, then we'll use a non-statin. At this point, then we can start calcium channel blockers, but only at that point, okay? Not during the acute episode. Okay? Here's calcium channel blockers again for unstable, chronic stable angina because of its vasodilating effects. Okay, let's go, and then here's the statin. So make sure before you discharge the patient that they have all of these on the discharge order. They have prescription for all of them. It's easy. They make your job easier now because there's a checklist. All you need to do is make sure the prescriptions are there. All right, so we have a patient who was taken to a hospital with no cath lab. So here is your thrombolytic therapy. We tested this already in stroke, correct? Or did we not?
We did.
We did? The absolute and relative? And anyway, I'll take a look at the test if I did. If not, then it'll be on the test again. And just like a patient with stroke who receive alteplase, the same monitoring, nothing different. All right, so these are your evidence that your therapy was successful. Okay, so that the clot has been dissolved. These are your signs. So if these appear, then that means it's been resolved. So depending on the type of ventricular dysrhythmia though, so for here, PVCs, as long as it's not BTAC or any other serious dysrhythmia, it's fine, meaning it's expected after you reperfuse. It's, I couldn't really understand why. Let me get a shot on it. So after you, I'll attempt, okay, to replicate what my instructor told me. So after you reperfuse or open the artery, as oxygen and calcium is brought back in, because remember we had 100% occlusion, right? So it killed the parts of your heart, parts of the myocardium. So we have some dead tissues there. All right, so a dead tissue, or some of them may be, so at that point it's not scar tissue yet, so they are dead tissue. And then, however, you have some dying tissues as well. So when calcium goes in there, in those cells, as blood goes back in, there is, the calcium will still make the cells contract. So that's why you may have some, what we call contracture scars, okay, meaning the cell will, or the tissue will contract. However, they cannot relax anymore. So that will cause these dysrhythmias here. Okay, so because that will now cause them to be irritable. And of course, dead tissue cannot conduct electrical impulses anymore. So that will trigger the appearance, or the occurrence of ventricular dysrhythmias, particularly PVCs. The SD depression or T wave, these will of course be resolved if we were successful in getting to them within 90 minutes, within the 4 to 6 hours, so that will also resolve. And instead of 24 hours, your biomarkers will peak earlier. Does that make sense? Meaning instead of the 24, because you were able to reperfuse, you were able to restore blood flow, so it will peak earlier now. But it will still stay elevated, especially your troponin, TNI. It will still remain elevated up to 10 days. Okay? You'll just peak sooner because you were able to restore the perfusion to the myocardium. So questions on the test with any procedure, angioplasty, PCI, open heart surgery, or CABG or bypass surgery will be pre and post-op. Pre-op, there's not much questions because the preparation is the same other than clipping the hair on the groin. Let me just emphasize clipping, okay? Only electric razor. I know of a nurse before who shaved the patient clean. I mean, as bald as a baby, okay? This was a 80-year-old patient. And then the patient apparently had a cardiac cath before. And then when the nurse was shaving her, and she asked, "No, is this really necessary?" And then the nurse's answer was, "Yeah, of course, because the the hair harbors organisms, and then the less hair we have, then the less likelihood we'll have bacteria." And then the patient said, "Oh yeah, that makes a lot of sense." So she allowed the nurse to continue, right? And then of course that is against SCIP, surgical care improvement project. We're not supposed to shave, right? We're only supposed to clip the hair. Of course, the nurse was written up, and I was that nurse.
Of course you were.
After the procedure, every patient must undergo cardiac rehab. Where and how soon depends on the patient's recovery. I'm not testing this, so just nice to know. Okay. So they can do inpatient rehab or outpatient. Most of our CAD patients or ACS patients are 65 and older. So here are some patient-centered care for the older adult having coronary artery disease. It's not really that much any different from the others, but there are a few, especially the exercise is concerned. So this part right here, I do have a question about that one. We already did the coping. I mean, I don't have questions about these because again, it'll be the same. This is a life-changing event. Patient feels lucky that they made it. Dysrhythmias. Your dysrhythmias will include sudden cardiac death, especially if the patient suffered a massive MI. So they could throw a ventricular fibrillation or pulseless VTAC at any time. So watch them for dysrhythmias. We'll discuss that next week. And we'll discuss cardiogenic shock in chapter 37. That would be week 13. Or 14, because I remember they said that the specialty tests will be done on your week 13, and I don't know what time you'll finish, so pretty much there'll be no class on week 13. So that means shock and burns will be on week 14. But we will have class on week 12, okay? After the exam on week 12, after the 31st, we have class on that day, okay? So don't go planning any party after that test. Managing left ventricular failure, they particularly emphasize this one because what is the most commonly occurring MI? What does it affect? Which side?
The left ventricle.
Okay, the left side, the left ventricle, namely because they will affect the LAD, RCA, and LCX. So mostly the arteries supplying the left side. These are your indications of decreased cardiac output. This is not shock yet, but you can consider this early signs of shock. Nothing really exclusive. I mean, you see this in most cardiac conditions. Let's review hemodynamic monitoring. So what are the values again? Right here. This was discussed in third semester. So right atrial pressure is the right side of the heart. This is your normal range. Please take note that although it's normal, there is no zero. And some of you guys, your textbooks might say 1 to 8. That's also normal. However, take note that there is no zero pressure. A zero pressure is already shock. So when we're dealing with a heart attack patient, we don't really want it around 2. Meaning the normal pressure would somewhere be around 4 to 6. Is that understood?
Yes.
Okay.
Yep.
So here's your review again. Right atrial pressure refers to pressure on the right side of the heart. So if you have heart failure or an MI, whatever condition causing decreased contractility of the heart, it will increase because blood is not moving in and out of the heart. So therefore the pressure rises. It's typically low if the patient has any hypovolemic episode, whether they're volume depleted or bleeding, for instance, or as a result of too much diuretic therapy, for instance, because these patients do develop heart failure after an MI, so they'll be on diuretics. It may also indicate that maybe you've given too much diuretics. Whereas the left side heart pressure, this is your normal range between 4 and 12. Again, if it's elevated, that means this is the left side. So that means blood is not moving in and out of the left side. So the numbers would of course be higher than 12. And just like our AP, if your patient is volume depleted, then it will also indicate low pressures. Okay, meaning patients dehydrated or volume depleted. The left side heart pressure will also be, of course, low. Here's the examples here. All right, so please read that. Again, it's just basically PAWP and RAP, or otherwise also called, this is also called CVP, central venous pressure, right atrial pressure, same right side readings. So left side readings are PAWP, or you come across PAOP, same thing. They're all left side pressures. Of course, all of this is possible only if you have a Swan-Ganz catheter. Okay, this is the pulmonary artery catheter inserted by the doctor to measure those pressures inside the heart. We did this already in third semester, so prepare for questions again. I do encourage you read chapter 35, not chapter 38, because this one is not very descriptive. So use chapter 35. Okay, we'll come back to this in once we get to chapter 37, week 14. I will skip that for now. These drugs are also for shock. So for exam 3, I'm not testing these yet because this is now for cardiogenic shock right here. So this drug therapy here is referring to cardiogenic shock. Okay, so from here, it's all about cardiogenic shock. So from this box right here to drug therapy, all of these are for, these are your vasopressors, dopamine, dobutamine. These are all under cardiogenic shock, which again is for the final exam. So I'll just take that off of exam 3. The other interventions here, which are more for critical care nurses, I'm skipping all of these. So the IABP, okay, next part is this one, PCI. So this is now for the procedure. It's nice to know. It's like I said, it's nice to know. Please read this so that you understand what they do. I don't have questions on the procedure itself. The question will again be only in the pre and post-op. However, to understand your post-op responsibilities, it would help though if you know the procedure. That way you understand, oh, that's why I do this, because they did this in the cath lab. All right, so the access site here is no longer the femoral. The before, in the 2000, early 2000s and before that, we were using the femoral artery only. But with advances in the catheterization science, we now use the question.
What artery you said that they were using?
Femoral. Now we are now using the radial. So because there were a lot of complications with the femoral, most common was bleeding because it's a way larger artery, obviously. And also a false aneurysm will develop. Basically, it's a hematoma. So we get hematomas there in the femoral artery. The patient has to be on bed rest. Which, is it good to put someone on bed rest with a heart condition?
No.
No, because that will mean, they have DVTs, plus they just underwent a vascular intervention. So that means they have the varicose triad, plus you add the venous stasis from immobility. So a lot of risk factors there for DVT and PE. So with the advent of using radial arteries now, we don't have to put them on bed rest. So they can be up out of bed right after the procedure. So they don't have to stay in bed. They can be up out in a chair, right? So we avoid the risk associated with femoral access, because in femoral artery access, we have to put the patient on during the last time I practiced was 2013. So at that time, we were still putting the patient up to 6 hours on bed rest. They were supposed to be on flat or for 6 hours, and then we put sandbags over the femoral artery, and we check it every 15 minutes. It was such a hassle. So now we have good closures now on, I forgot the name of the thing we use for radials, but they're very effective. We hardly get any bleeding or hematomas on the radial artery. This is you've come across this, right? Last semester. This was used for HIT, remember? If a patient has heparin-induced thrombocytopenia, we use Angiomac instead. So this is the same thrombin inhibitor, direct thrombin inhibitor we use for cardiac catheterization. So there's no clotting when we put in the catheter. I have no question on other procedures. Okay, let's go to bypass graft now. So who will undergo coronary bypass instead of cardiac catheterization? So these are your indications. So if the patient has any of these, then they cannot have a PCI. So they'll have to have open heart surgery. the most ideal graft use is the internal mammary artery. You see the picture right here, right here. So this is the internal mammary artery. So unlike vein grafts, wherein you harvest these vessels from the leg, wherein you have two sites of anastomosis. You have anastomosis here, anastomosis here. And then depending on how many vessels, how many grafts you use, the number of um, um, anastomosis sites. So this one, you only have one because this is the internal mammary artery branch. So it comes out of the aorta, and then you simply take it out from the breast and put it into the heart. So less incisions, because these ones you have to take these from the leg. So you have to harvest these endoscopically. At least they do it endoscopically now, rather than long, 12-inch leg incisions. Not anymore. We harvest these with two small, 1 to 2 inch incisions from the leg. But really, this is better, way better. Plus, this is an artery. It's built for the purpose. It's an artery, whereas these are veins, so they're not as strong as arteries. Okay? Imagine imagine high pressures that these grafts have to withstand. Okay? So this is way better than your saphenous veins. All right, so if the patient undergoes coronary artery bypass graft because they can't have PCI, of course, your pre-op will be, if they're Italians, really hairy chest, then clip the hair. They will be given showers. You don't have to give the shower. I mean, patient can get up, okay? So the patient gets up in the shower, they take a shower. They do use this antiseptic soap. So this is Hibiclins, 4% chlorhexidine. They may need to have 2 showers also. One the night before and then one the day of. Some doctors are anal about that. They want 2 showers instead of 1. And the chlorhexidine soap, I used to, for lack of a better word, steal these from the hospital. These are, of course, ones left over. Okay, so I use a chlorhexidine soap on a patient. They didn't use it, instead of throwing it because it didn't really have contamination. Because you pour the soap out, it's not like you return the soap inside the container. Okay, so all I do is wash the bottle and then take it home. Okay, they smell good and you feel good because you shower with an antiseptic. You feel very clean, ready for surgery. For post-op, of course, you crack the patient's chest open, you crack the sternum open the ribs, access the heart, open the pericardium. So, of course, there'll be a lot of drainage there. So you will put chest tubes, and because you put the heart through this machine here, this is the heart-lung bypass. So the patient's heart stops and circulation is done by the machine. So we put the connections here. So blood continues during the procedure while the heart is not pumping. And so after the procedure, after they remove these, and no, they don't remove it yet. They have to make sure the heart pumps back first. So we need the pacemakers. So you will expect, besides the drains, the patient will also have, where is it? Post-op. Where is it? Okay, here. So the patient will need pacemaker wires when we restart the heart. So there will be a external pacemaker. It'll be removed usually the next day, or sometimes even before that, several hours later, the pacemaker wires will be removed. Your job, of course, is to make sure the chest tubes are draining. Okay, you already know how to manage chest tubes. So this chest tube just happens to be in the heart, in the pericardium instead of the pleura. Just make sure it's draining. If it stops draining, patient develops cardiac tamponade and death will follow. What are the signs of cardiac tamponade again? What are the Beck's triad?
The muffled harsh sounds,
Good. What else?
and I don't remember anything else.
There's the jugular vein distension, right? And the pulses. No, there's a wide pulse pressure. Sorry. And hypotension. Okay. Hypotension. Okay, so that's the heart-lung machine. That's your bypass. Post-op. So your incision care, pretty much none for the chest because there is no, the closure they use now is glue. So they just use Dermabond for the chest incision because the sternum was wired shut already. So there's really no sternal incision to speak of. Sometimes they do, but lately I haven't seen any since 2000. Yeah, since the last patient I saw was 2013. We weren't using it, the surgeons weren't using any staples or sutures anymore. So it's just glue. The legs, though, you will have incisions there. You will have staples or sutures in the leg incisions if the veins were taken from the legs. And of course, if it's an internal mammary artery used, then you won't see any leg incisions, just a sternal incision. Complications of coronary artery bypass grafts. So here's cardiac tamponade. So please, again, review your Beck's triad. That will be on the exam again. I have no question on this, nor this part. I mean, these are not common complications. So just stick with these right here. Okay. Although the explanations are in these paragraphs that follow, but keep your readings on these, okay? Just what's mentioned here. So since it didn't really develop, I mean, mention hypothermia, you didn't see hypothermia on this list, right? Oh, there is, sorry. So yeah, there it is included. This is the difference in the in the mediastinal tubes. So we have Constavax, where the drain, especially if it's the internal mammary artery. So we're expected to see more drainage here because you use the internal mammary artery. If you get more than 500 or more for of blood, it will be auto transfused to the patient. It's their own blood anyway. Oh, here's the Beck's triad again. So you don't have to go to the chapter 35 anymore. It's here. It's not a chart, so it's a critical rescue box. So your early sign is sudden cessation. That means it's obstructed, and now the blood is accumulating inside the pericardium. They have nowhere to go, so the Beck's triad will appear, and of course the patient will go into shock, obstructive shock. Okay, we're almost done. You can skip all these here. I have no questions on these parts. Nope. And post-pericardiotomy syndrome is already part in, we talked about this in pericarditis in chapter 35. I have no question on mid-cab. This is just nice to know. This is how they harvest the, the veins from the legs. So 2 small incisions, and they put instruments through to harvest the vein. So here, instead of the 10, 12-inch long incisions we used to see before to harvest the leg vein, we have 2 very small incisions now. I have no question on laser or off pump CABP, no robotic surgery. Okay, we're on the discharge now. This chart is redundant. My last question is on, let's see. Is it this one or, let me just was it 3810 or 38? No, not 38.9, it's 3810. Okay. As far as activity goes, you already know this one for smoking cessation, exercise, and all that. So that wasn't new. So here is your after open heart surgery. This is now your teaching. So they gradually increase activity. They carry nitro when they do the exercising. If these symptoms come on, stop, rest, and then take your pulse. Here's the exercise. No definite strenuous activities. So lifting, push-ups, none of that. And including Valsalva. One very important question is when can they resume sexual activity? So that is here. Instead of the best evidence-based instruction is not on the time period. You'll see somebody say, after 46 weeks, not really necessary, because can you go without sex for 46 weeks?
No.
Yeah, that's hard. So the better basis would be the level of exercise tolerance. Okay, so the patient here, it's after a certain exercise tolerance. So if the patient can walk a block or climb stairs without symptoms, okay, that's the basis. They can walk a block or climb 2 flights with no shortness of breath, nothing like that, then they can safely resume sexual activity. At what level though, or what role they play, that's a different story. So if they were used to being the active participant, that's probably not the best way to resume. Okay, so you may have to assume a more passive role in the activity. And this is the last part. This is again to summarize the drug therapy. These are what the patient will be discharged on: aspirin, Plavix. Let's start here. Where is the here? Aspirin, beta blocker, calcium channel blocker, statin, and the nitroglycerin. And here's the this is your Plavix or clopidogrel, and here are the rest of the drugs: ACE inhibitors and or ARB. So, and Tresto, you're familiar with it, right? You have an ACE inhibitor and an ARB in Tresto. This is not new. We covered this in chapter 35 in 3rd semester. So NSAIDs are contraindicated now for patients with cardiovascular history. And we already did the nitro, so we're done. And these are not also new. We did this already in chapter 35 in the symptoms to report. You remember MODS, the acronym MODS? MAWDS?
Yeah.
Education activity. Okay, wait. All right. So on the S part, the symptoms that signs and symptoms to report, these are the signs and symptoms to report. So we had the weight or increase. These are just stated differently, but pretty much the same thing. When you have an increase in the symptoms, let's say in chapter 35 though, they say about the increased number of times that you have to get up to use the bathroom at night, or increase in the activity intolerance. They're just stated this way. Let's say, for example, this one. Of course, this one means decrease or decrease activity intolerance, because now with activity they have symptoms, right? So it's the same thing, just stated differently. Because remember, these patients do develop heart failure with the ventricular remodeling. And that's it.